Welcome back to Ophthalmology for undergraduates and postgraduate beginners. Today I am going to continue with proptosis. How to diagnose a case of proptosis. How to find out the etiology. Proptosis can be broadly classified as bilateral proptosis affecting both the eyes, unilateral proptosis affecting only one eye. First, we will talk about the bilateral proptosis. Patient having forward displacement of the eyes on both sides. Whenever you consider about bilateral proptosis, this is connected with a disease outside the orbit. It may be from the skull or it may be from the body. So, coming to the differential diagnosis of bilateral proptosis, the first and foremost diagnosis that should come to our mind is a hormonal problem, that is thyroid disease associated with proptosis. It may be a thyrotoxic proptosis or a thyrotropic proptosis. The next thing is the congenital defect in the development of the person. The person having a congenital defect in its development. So, there is a improper development of the cranium and the face, that is called as craniofacial dysostosis. In some conditions of this craniofacial dysostosis, the orbits may be very shallow. They may not be deep, so the eyeballs will be projected outside. Example is oxycephaly. Next is systemic malignancies. A person having a leukemia or lymphoma in his body, this leukemia or lymphoma or lymphosarcomas can infiltrate various parts of our body. It can infiltrate the orbits also. So, these people can also have bilateral proptosis. Next, the systemic diseases like amyloidosis, histiocytosis, Wegener's granulomatosis, Mikulicz syndrome. What is this Mikulicz syndrome? Mikulicz syndrome is enlargement of salivary glands and lacrimal glands due to infiltration by lymphocytes. Next is rickets. So, these systemic diseases can also present with bilateral proptosis. Next is the disease of the skull. From the skull, some disease may lead to bilateral proptosis. The most common thing is cavernous sinus thrombosis. Whenever the cavernous sinus is infected, inflamed or thrombosed, naturally it will develop as a unilateral proptosis and later on it will go to a bilateral proptosis like features. So, whenever we talk about bilateral proptosis, it can be either exophthalmos due to thyroid disease or it may be due to one of these diseases. Whenever we talk about unilateral proptosis, we should have one thing in mind. All bilateral proptosis does not develop symmetrically. They can start on one side and they may involve the other eye. So, all the causes for bilateral proptosis should be considered in unilateral proptosis also, which may become bilateral later. Coming to a discussion of unilateral proptosis alone caused, these are the differential diagnoses. Unilateral proptosis can be classified as acute, a chronic, intermittent and pulsating proptosis. Acute proptosis, whenever there is a foreign body in the orbit which is not being removed, that will cause an inflammatory reaction and proptosis. Orbital cellulitis, inflammation of the orbit, so the entire orbit is inflamed leading to proptosis. Emphysema, what is this emphysema? Air is leaking into the orbit, pushing the globe outside. This may be due to the fracture in the orbit leading to leakage of air from the sinuses, most commonly the ethmoid sinus. Next is hemorrhage, retrobulbar hemorrhages. Most of the time, whenever we give a injection, that is the anesthesia of the orbit for doing a surgery, a retrobulbar hemorrhage can occur leading to a proptosis. Next is rupture of ethmoidal mucosals. The sinuses can have mucosal development. When these mucosals, they become very big and rupture into the orbit, it may lead to a unilateral proptosis. Coming to the chronic causes for unilateral proptosis, the first thing is the pseudotumor of the orbit. Orbital apex syndrome, we call it as. The globes are being pushed outside. Next is tuberculoma caused by tuberculosis. Gamma caused by syphilis. Sarcoidosis. Parasitic cyst like hydatid cyst can also lead to chronic proptosis which develops over a period of time. Next is intermittent proptosis. In some people, the proptosis may be there for some time, then it may resolve. Once again, that may come out and that may resolve. In which conditions it will come? One is the orbital varices, the venous tumors of the orbit, orbital varicocele. We call it as varicocele in some other parts of the body. Here we call it as orbital varix. Next is the recurrent orbital hemorrhage. In people having bleeding disorders, recurrent hemorrhages can occur in the orbit leading to a proptosis. Highly vascular tumors like hemangiomas can suddenly become bigger and the proptosis will be prominent. They may resolve for some time. So those things also will lead to unilateral intermittent type of proptosis. Most interesting thing is the pulsating type of proptosis. The globe will pulsate. So this will come and go. When you see such a pulsation, if you touch those eyes, you can feel a thrill that is called as orbital thrill. When you hear with the stethoscope, that is called as bruit. So the common causes are carotico-cavernous fistulas. The cavernous system and the carotid system, they develop a connection so that the arterial blood is pumped into the cavernous system leading to its pulsation. So that can lead to unilateral pulsating proptosis. Next is aneurysm of the ophthalmic artery. It may be due to some diseases. There may be aneurysm developing in the ophthalmic artery, or it may be due to a trauma leading to aneurysm of the ophthalmic artery, leading to unilateral pulsating proptosis. Orbital roof defects. Whenever the roof of the orbit there is a defect, what will happen? The cranial cavity will have a communication with the orbit directly. They may have meningocele or meningoencephalocele. The cerebral pulsation will be transmitted to the globes, leading to pulsatile type of proptosis. So these are some of the conditions that can have unilateral proptosis alone. In proptosis, the eyeball may be displaced directly forwards, or it may be displaced forwards and in one of the directions like out, in, up or down. Based on that displacement, we classify proptosis as axial proptosis and eccentric proptosis. We know that the eyeball is located in the orbit. All the muscles of the eye are arising from the apex of the orbit and they are forming a cone-like arrangement to get inserted into the globe. If there is any disease within this cone-like arrangement of this muscle, that is in the conical space behind the globe, then that disease will cause axial proptosis. That is, the eyeball is directly shifted forwards. If there is any disease outside this conical space, that is a muscle cone, then depending upon the disease, which side it is present, the globe may be displaced towards the opposite side. Let us see some examples for axial proptosis and eccentric proptosis. Whenever there is a tumor of the optic nerve, that is the glioma or meningioma of the optic nerve, which is located within the muscle cone, then that will cause a axial proptosis. Orbital varices, venous tumors will be very common within the muscle cone, leading to axial proptosis. Caroticocavernous fistulas can also lead to axial proptosis. Retrovulvar hemorrhages can lead to axial proptosis. Thyroid diseases can lead to axial proptosis because it causes inflammation of all the structures inside the orbit. Next, coming to the eccentric type of proptosis, we will see some examples. If there is a lacrimal gland tumor here, that will push the globe down and in. If there is a ethmoidal mucosal on the inside, that will push the eyeball out. If there is a meningocele, that is the defect in the superior portion of the orbit, then that meningocele will come down from the cranial cavity, that will push the globe down and out. There are so many conditions that can cause axial proptosis and eccentric proptosis. With this, we will stop here today. We will talk about the cases kept for exams for undergraduates from the next session onwards. Thank you.